triaging the patient, whether it is mild, he is in mild category,
So,
moderate or severe.
so the first thing you are thinking, your first thing you are thinking is you need a score to triage a patient.
Categorize whether it is.
So there are a few reasons why you do the scores. Okay, if you ask me what are the reasons, one of the reasons is say today I have a patient that is in say in Bandra and patient has fallen down. And now somebody needs to contact you and tell you what is the situation because they are going to get that within an ambulance. Somebody fallen for some reason, stroke, IC hemorrhage, whatever. Now that person is at Bandra and wants to communicate to you. This is the situation.
Yeah.
Okay. Now to say what situation it is, he will, what Alia might say, patient is not moving well. Chandrima might say that eyes are opening. Niharika might say the hands are moving fast. So we need a unified way to talk to each other to understand what is happening. So if she calls up and says the GCS is 7/15, you are clear what is happening.
Yeah.
You are clear that this is something that is very serious. This is something that is very serious. Okay, when you say GCS less than 8, it qualifies as coma. What is coma? Unarousable unawareness. When you say coma, it's unarousable unawareness. So any GCS of 8 and less than 8, we know it's comatose. So I know that what I am dealing with from far itself. Okay, this is what it is. So it's a unified score which gives us an idea as to what this patient is about. It's unified. So it's what you are saying, what she's saying, what she's saying would remain the same when you say GCS. That's why you have a score. Number one. The second thing is, today I want to do, say for example, this patient had IC hemorrhage and I want to do a form of therapy. I don't know whether this works. Okay, now for example, take the example of mannitol. Now I want to give patients mannitol. But GCS 14 and GCS 8 will respond in two different ways. You understand? So GCS 18 and GCS 8 will respond differently. So the effect of mannitol cannot be judged unless you have a group of patients that look the same. That is this place to switch on. Okay? Thank you. So you understand? Huh? So, अगर समझ लो I use mannitol in a person who is 15/15 and I use in a person who is 8/15, the response will be different. So I now need a benchmark with which I can do my clinical trial for this mannitol. I need a benchmark. I need to say that in a group of patients whose GCS is less than 8, I'm going to try mannitol. Or in a group whose GCS is 10 to 12, I want to test mannitol. So it gives me a point in which I can do my clinical trials. You understand? I can do it to understand the drug. Otherwise, how do you understand the drug? You will not understand the drug. You understand? So it gives you, this is the second thing that it does. The third thing it does is, it possibly gives you a sense of prognostication. It gives you a sense of prognostication. This can't be complete prognostication. It gives you a sense that GCS is low means the overall prognosis is not good. We'll come to that when you actually do ICH score. Okay? We'll come to that when you do ICH score. So when he said GCS, few important points that he alluded to was the motor response, which is probably the most important part of your GCS. The motor response is probably the most important part of your GCS. When you say motor response, it is probably the most important part. So among all the parts, eye-opening, motor and verbal, what is found is that the motor response is the kind of most important part when you're dealing with it. So you have to know the Glasgow score at the tip of your tongue. You can't really refer to it at that time because of the fact that it is so important to know this particular score. This score was devised actually for traumatic brain injury. It was not devised for a metabolic encephalopathy. It was devised for a traumatic brain injury. So needless to say, it is in traumatic brain injury that this GCS is work best. It will work best, right? Now in that motor score, there are a lot of discrepancies in the way we do stuff. So when you say flexion response to deep pain stimulus, what is deep pain stimulus? When I say deep pain stimulus could vary in different. So what is the recommended deep pain stimulus that you need to give to these patients? You need to give deep pain stimulus, right? So what are the deep pain stimulus that you take? No.
This will bring strain.
No. That's the point. See, you understand? So he said sternal rub. He said pinching. What else? Tenderness. Then what else you think? So you have to have a specific way to do motor response. You can't have different ways of motor responses. You understand? So this is completely wrong. When you say GCS tenderness, what he says is completely wrong. So what is the right way to do it? The right way is when you have a patient in front of you is because the motor response is so important, you have to have the right way to do it. What is the right way to do it? The right way is to keep the hand in the front. Keep the hand in the front of this particular patient and give three kind of responses. The first response is nail bed pressure. The first is nail bed pressure. That means I take a pen, keep a pen, press the nail bed. Nail bed pressure. That is what is recommended. Which one?
Nail bed.
Nail bed pressure. The second is the supraorbital tenderness. Supraorbital pressing. The supraorbital nerve to be pressed. Supraorbital nerve. Okay. So you press the supraorbital nerve. Okay. Supraorbital nerve. And the third is anyone? Third one? No. Trapezius pinch. Trapezius pinch. Trapezius pinch. There are only three things you are supposed to do. Okay. There are only three things. The rest, sternal rub, pinching is obnoxious, not supposed to be done, not something that you will do. Okay. But if you want to really do the GCS the right way, these are the three places you are going to do this. So which are the three places? If I repeat, it is nail bed pressure. Now how do you do this nail bed pressure? Take a pen, keep the pen, press it, nail bed pressure. Okay. The second one is supraorbital pressure, tenderness, supraorbital pressure. And the third thing is trapezius pinch. Trapezius pinch. That's why when you actually, if you have a patient that is lying in front of you, trapezius pinch is something you can do quickly. You just press the trapezius and you know what the GCS is. Now what is the response? What is the response you are eliciting? Now the hand is like this, right? What is the response? What should be the response when you say flexion? Hand is already flexion, so what should be the response? If you are saying normal, the normal response would be moving away from the body. The normal response, if you press here, if I press you in your sleep here, you will move your hand like this. That is normal flexion. Away from body. Okay? Away from body is normal flexion. When you say abnormal, means when you are pressing it, what is going to happen? You are going to have this moving inside and the legs extending. That is abnormal. So you see what is happening here? This is abnormal flexion. Okay? That means it's instead of going this way, it is happening this way with the legs extending. Okay? So that is abnormal flexion. You must understand this very important because the motor system examination is kind of the most important when you think about GCS. You know this? Yeah. Any doubts on this now?
No, sir.
Which response do you take? Now you have a patient in front of you. The first response was this. Within some 2-3 minutes you test again, we give like this. So which is the response you take? The best response. The best response is what you are basically going to say. The best response. Okay, it's not the worst response. So when you ask somebody, you say normally worst. Many people say worst response. It's not the worst. It's the best response you take. You understand? The best response. So if he does flexion even once, that is his best response. So now that response is very, very important. Clear? Okay. This is about GCS. Let's go ahead. So less than 8 is coma. Less than 8 is coma. Anything 30 to 15 is mild, and between that is moderate. Moderate traumatic brain injury. So whenever you talk about GCS, our thinking is GCS is TBI, traumatic brain injury. Okay, we don't really look at GCS. Though we want it, because it's a unified term, we keep talking to each other GCS because it's a unified term. But that's not been proven for, say, a stroke, or not been proven, say, for example, metabolic encephalopathy. You understand? It's not obvious. Say, for example, you have a patient who had hypoglycemia. He had hypoglycemia. When the patient comes in hypoglycemia, the patient is comatose. Patient is comatose. There will be no response to deep tension. Nothing will happen. Hypoglycemia, complete hypoglycemia. You say the GCS is 4/15. Okay. Now, once you say 4/15, what do you start thinking? Prognosis kharab. We just talked about prognosis. We said that okay, if I have a GCS that's very low, less than 8, it is a coma. And the coma prognosis is bad, isn't it? Coma prognosis is bad if you think like that. But what happens in hypoglycemia? You give them sugar and they'll become normal. They'll just become normal, talking to you, walk to you. So that prognostication doesn't become good in metabolic encephalopathy, or for that matter, meningitis. You have patient meningitis will come. You intubate this patient because patient is down completely. For example, the lady down there. So say that lady down there is intubated because coma is GCS is 3. We have intubated her. Now that is not traumatic brain injury. That is not traumatic brain injury. Now there is a high possibility that this is an infective focus because she had a history of fever. Now if she has an infective focus, it's a history of fever. Infection is something that can be treated. It is something that can be treated, isn't it? Now, if I treat this patient and the patient becomes completely normal in say 2-3 days time from now, say 7 days time, the GCS again is not right, no? Are you understanding GCS again or not? Because you have said that this patient is completely comatose. My entire reason to do that entire investigation is to find whether there is an infective focus that we can reverse. If we get an infective focus, reverse it, patient will become better. Are you understanding? Huh? That's how it is. Clear? She's come positive? So now it's reversible. So now the GCS is different. Now in phase rickets here. Okay? If that's positive, very rare though. It's very rare to have something like this. But I think she'll turn around if that's the case. Huh? So let's go to, you understood now?
Sir, these patients would have been intubated or not? Because in this patient GCS...
Why is intubation here?
Because of the low poor GCS.
Why you want to intubate low GCS?
Yeah.
That's all. So that remains the same.
When she came, she was maintaining her airway, everything.
She will maintain airway, but what if she aspirates? She will die because of aspiration. She's not going to die because of the brain. She's going to die because of aspiration. Okay? Brain की वजह से कोई मरने तो नहीं वाली है. Brain is not going to kill her. You understand? She's going to die because of aspiration. So the reason for intubation is completely different there. It is not related to this. So the airway protection something is you do because with a brain that is down, with a coma that is down, patient is not going to die. The heart is not going to stop. His brain that occurs only when the brain is like a huge ICP, raised ICP, and that anyway is going to intubate. It's not going to be like that. These patients are going to die because say they will aspirate, they will have an infection, and then they will go down. You understand? Yeah.
Next code is intracerebral